health.uga. And so part of that is this research symposium. And like Dr. Davis-Olwell said, this is our second annual research symposium, and we are just thrilled to have so many terrific submissions this year. Our judges have viewed all of the presentations this week, and we really want to thank them for their time and feedback. So without further ado, let's go ahead and get started with the oral presentations. We're going to have about 5 to 7 minutes for each presentation, followed by just a few minutes for questions. And so if you all could put your questions in the chat, that would be great. And then we'll go ahead and read those off afterwards. So Trung, are you ready? I'll pass it over to you.
And I think everyone can screen share. Okay.
And just a reminder, I'll be putting a 1-minute warning in the chat so we can stay on schedule, Trang.
Trung, your screen doesn't show yet.
Juliet, this is Chris. Let me suggest, in the interest of keeping things moving forward, why don't we communicate with Trang behind the scenes and move on to the next presenter. And then if we can get Trang online, we can bring her in.
Okay, I'll do that right now. I think she's having some technical challenges. Okay, I'll do that.
Okay, that'll be great. I think that Devin is the next presenter. Devin, are you here? All right.
Yes, I'm here. Can everybody see my screen?
Yes, we can.
Okay, thank you. All right, well, first I want to thank everybody for this opportunity, everyone in the Global Health Institute. So I'm going to get started. I'm going to talk to you all about a pretty novel way of characterizing exposure. It's titled The Rapid Assessment of Indoor and Outdoor PM 2.5 Levels in Rural Jalapa, Guatemala. My name is Devin Campbell, and I'm a third-year PhD student in the Environmental Health Science Department. So I'm going to first start by introducing household air pollution. Now, this is a global issue, and it's global because approximately half of the world's population relies on biomass as fuel to both cook and to heat their homes. Now, the combustion of these fuels results in air pollution inside the home that is attributable to approximately 4 million premature deaths annually. And these deaths are primarily seen in low and middle income countries. Now, some efforts to mitigate the adverse effects from this household air pollution involves improved biomass cook stoves, where these are mechanical improvements to biomass cook stoves, or cleaner burning stoves, which use cleaner burning fuels like liquefied petroleum gasoline stoves, electricity, and sometimes even ethanol. And as it stands, even still, the effectiveness of these types of interventions remain inconclusive, mainly due to the inability of these interventions to decrease exposure to levels that provide a benefit to the intervention group, a significant health benefit to the intervention group, I should add. So now enters the Household Air Pollution Intervention Network Trial, or the HAPPEN trial. Now this is a multi-country intervention trial of LPG fuel, stove and fuels. And it's multi-country because we have sites in Rwanda, India, Peru, and Guatemala. And so I'm going to talk to you a little bit about the formative research phase in Guatemala. So this map to the left shows Guatemala as a whole, and the highlighted in gray is the Jalapa department. Now the map to the right shows this department blown up, and we get to see the 4 municipalities that are that were considered for the rapid assessment. So we have San Carlos, Jalapa, San Pedro, and San Luis. Now, in interventions of this type, there is normally some type of health survey where field technicians go out home to home, door to door, and they ask questions to get a sense of the study population as far as what type of stoves people usually use, who are the predominant cookers in the home, just simple demographics of that particular area. Now, a typical way that we characterize exposure in these types of programs is that for each monitor we use, we set them up in early in the day, and then either in the kitchen or the outdoor environment, and we have that one measure for 24 hours. But for this novel, the reason why this particular study design is novel is because what we figured, well, since we're sending out people to go to these homes door to door anyway, let's fit these technicians with personal air monitors where we can then get a rapid assessment. And this is rapid because you're only getting 15-minute samples of the kitchen environment and the outdoor environment. And we get about 10 homes per day in this particular study. So this map shows all the clusters with exposure data for the rapid assessment. Each square you see is 1,300 by 1,300 meters in area. And within each square, we have data for, on average, 10 homes. And within each home, we have a kitchen measurement, a 15-minute kitchen measurement, and a 15-minute outdoor or patio environment measurement. Now we use this information to answer the simple question: is Jalapa a good site for an intervention trial? And in order to prove this, we must be able to show the potential for a population level exposure contrast. In order to do this, we need to know two things. When there is a cooking event, are those levels high? And we also need to know when there is no cooking event occurring, what are those levels? Are those levels low enough? Are we getting some type of a signal from ambient sources? These are some things that we need to know. So these two figures show basically the same information. So I'm going to gravitate your attention to the black circle here, and we see that in kitchens that have a cooking event, we see a geometric mean of 62 micrograms per meter cubed. Now, this is approximately double the WHO air quality guideline for daily exposure, which is that dotted line that you see in the figure to the right. And this black circle is analogous to the red circle that you see in the interaction plot to the right. Now, this first arrow shows a 76% decrease in exposure when we go from kitchens with cooking events to kitchens without cooking events. The second arrow shows a 53% decrease in exposure when we go from kitchens with cooking events to patio environment with cooking events. And this last arrow here shows a 77% decrease in exposure going from kitchens with cooking events to patios without cooking events. And what's telling here is when we see no cooking event at all, we see extremely, well, I guess I should say relatively low measures of exposure at 15 and 14 micrograms per meter cube. And even when we have a cooking, even in the patio environment with cooking events, we see that it's still below this WHO threshold. So in conclusion, we have preliminary findings of the rapid assessment that shows a potential for a high contrast in population exposure. We see this comparing both kitchen and patio levels and cooking events versus background levels as well. We see that background levels are below the WHO guidelines for 24-hour exposure, and this provides evidence that Jalapa, Guatemala is a good site for an intervention. I want to thank my major advisor, Dr. Luke, Lubnair, and my committee members, John McCracken, Dr. Wong, and Dr. Rathwin, and my co-authors, and of course my HAPPN collaborators and our funders. Without them, this work would not be able to be done. And that's all I have. Thank you. Any questions? Let's see if I...
So Devin, this is Dr. Whalen. On your figure where you show the indoor air pollution in the kitchen during cooking events and without, were those paired samples? In other words, you measured once while they were cooking and another time when they were not cooking, or are these different kitchens?
No, these will be different kitchens. So when the technicians go out, they would go to a particular home and they would just make a note whether that home was cooking or not cooking while they were there.
Any other questions? I don't see anything in the chat. Chris again? Dr. Whalen?
No, so it sounds good.
Okay.
Okay, well, I guess we can move on to Trong. Is he ready now?
She's not here, so just move to the third presenter. And she'll be.
Manaz, are you
after.
here?
Yes.
All right, perfect.
Can you see my screen?
Yes.
Okay, hello everyone. I'm Minaz Mawani and I am a second year PhD epidemiology student. And I am going to present this study titled Epidemiology and Outcomes of Out-of-Hospital Cardiac Arrest in a Developing Country. And this was a multi-center prospective cohort study. So survival after an out-of-hospital cardiac arrest has been reported to be poor, and even in developed countries, there are disparities reported between different counties. From developing countries, there is a lack of data on this, even though 80% of the burden of cardiac diseases is concentrated in developing countries. Therefore, we aim to investigate the rates of survival and explore the components of chain of survival in Karachi, Pakistan. So emergency departments of 5 major public and private sector hospitals of the city were our study sites, and combined these hospitals receive a population that is diverse in socioeconomic status and ethnicities and is largely representative of the general population of the city. We had a 24-hour data collection set up in these 5 hospitals by a team of our trained data collectors, and we included all adult patients presenting with out-of-hospital cardiac arrest to these study sites. These are the results of our study, and they are stratified by the type of pre-hospital transportation. For the fact that unlike developed countries where there is a universal number like 911 and a single network of ambulances providing standardized care, pre-hospital care and transportation is still in the developing phase. So this is the standard type of ambulance, but there is another type of ambulance which is not as equipped as a standard ambulance, but it provides a quick transportation to the hospital. And then there are non-EMS transportations like public and private sector transportations, where a lot of people feel that considering the traffic situation and city conditions, it can be quicker to just get a public or private transportation and reach the hospital. So mean age of our population was 59.2, and patients using ambulance with life support interventions were older. Time to reach to the hospital was shorter for non-EMS transportation. However, time to receive first life support intervention was the shortest for patients utilizing ambulance with life support interventions. However, these time intervals were still pretty late in the phase of cardiac arrest, which explains a very small percentage of return of spontaneous circulation and thereby leading to a small number of survivors. However, these numbers were still higher for patients using ambulance with life support interventions. These are the Kaplan-Meier survival curves, which show that survival times were better for the standard type of ambulance compared to the other two types. And most of the patients were not given CPR in the pre-hospital or hospital setting, except for this group that utilized ambulance with life support interventions. Most of the patients had non-shockable rhythms in our study population, and non-shockable rhythms are associated with poor survival outcomes. More than half of the patients were brought to the hospital in a public or private sector transportation. And even though about 93% of the patients had a witnessed arrest, only 2.3% received a bystander CPR in the field. So this is the first large-scale study for out-of-hospital cardiac arrest in Karachi, Pakistan, based on Epstein criteria, which is a standard for collecting OHCA data points. And we reported that there was a lack of bystander CPR and EMS systems are weak that led to delay in receiving life support interventions. And therefore, we emphasize the need to standardize EMS systems, initiate public awareness programs, and strengthen links in the chain of survival. We shared these findings with the scientific community in Pakistan, and they have established a registry to track down the survival outcomes of out-of-hospital cardiac arrest. Then there is another group of researchers who are providing trainings to general population in order to increase the percentage of bystander CPR in the population. And there is another study being conducted to understand the perceptions of general population regarding CPR. The study was funded by NIH Fogarty and partly by Aga Khan University. Thank you.
Great. So I see there's a question in the chat from Dr. Abel. Did you have any information on neurologic status at the time of discharge? And how many of the 5 survivors were neurologically intact?
Yeah, so we did have this neurologic information in CPC scores for these participants, and they were at the time of discharge, they had a good neurologic status. However, these patients in the long run did not survive. So even though they did get some time for survival, it did not lead to a long-term survival because the interventions that were even provided, they were so delayed in the phase of cardiac arrest that led to poor outcomes.
Any other questions? Oh, I see it.
Yes, this is Dr. Whalen. Manaz, thank you. That was a nice presentation, and you won't be surprised at my my question. Have you thought about using propensity scores to arrive at some sort of balance in the type of ambulance that was called and used?
Okay. So at the time when I did the study, I did not think about that. But now that I've studied the subject, integrated research designs with you and propensity scores, yeah, definitely.
Yeah, it'd be interesting to see what it would be as though it were a randomized clinical trial.
Yes. Thank you.
Any other questions? Okay, thank you, Manaz.
Thank you, Manaz. Okay, I think Henry is next. Henry, are you ready?
Yes. Okay, so can everyone see my screen?
Yes.
Okay, yeah, so my name is Henry Kitiabi and I'm a first year PhD student in the Department of Epidemiology and Biostatistics. And I'm happy to share with all of you preliminary findings from a study I did in collaboration with 9 other researchers on predictors of TB mortality. Sorry, on TB mortality among Kenyan hospitalized children living with HIV. Tuberculosis is a bacterial disease caused by a mycobacterium tuberculosis, and it affects approximately 1 million children annually. And about 95% of deaths occur in less economically developed countries, and Kenya is one of the countries that has been listed as a high TB burden globally. Looking at the studies that have been done in the past, we found nutrition, age, CD4%, WHO HIV stage, and poverty as predictors of mortality among children with TB and HIV. And so there are a few studies that have shown the epidemiology of TB mortality among children living with HIV in Kenya, especially in the context of early ART insertion. And therefore, this leads to our aim, where we were aiming at evaluating the cofactors of TB mortality among these hospitalized Kenyan children starting antiretroviral treatment. So we performed a secondary analysis of data from the pediatric urgent start of highly active antiretroviral therapy, randomized clinical trial of delayed versus urgent initiation of antiretroviral treatment in ART-naive hospitalized children who were at least 12 years and below. And the study was conducted between April 2013 and December 2015. And our outcome was TB mortality, and predictors that we settled for were NIH TB classification, age, monocyte to lymphocyte ratio, HIV viral load, and immunosuppression. So we first described the patient's baseline characteristics, and then we estimated the probability of survival using the Kaplan-Meier survival curves across the 3 NIH TB groups, which are confirmed, unconfirmed, and unlikely TB. We then performed a multivariate Cox regression analysis among children, and we restricted this analysis to children who had only confirmed and unconfirmed TB, and our sample size was 93. So here are the results. So the first figure is showing us the distribution of patients across the 3 TB groups, where we have the confirmed, unconfirmed, and unlikely. And here we are looking at those who survived and those who died. And you can look at the confirmed, we had more who died than those who survived at 54 versus 46%. Then figure 2 is a Kaplan-Meier survival analysis that is showing the differences across the 3 TB groups. And you can look at the figure on the y-axis, we have the survival probability, and the legend here gives the different lines, where we have the blue line with confirmed, the red line with unconfirmed, and the green line with unlikely. And you look at those who are confirmed to have TB had the least survival among the 3 TB groups. And so we found an overall 6 months mortality of 22%, and most of the deaths occurred in the first 2 months of follow-up. And the incidence was pretty high when you look at the groups of confirmed and unconfirmed, and we had 3.48 cases per 100 child months, compared to the unlikely TB group where we had 1.44 cases per 100 child months. The table here on my right is giving us the overall predictors that we found important in this study. And I'd just like to inform you that we had 8 variables that we entered into the univariate regression model, where we had the TB status, age, malnutrition, orphan or vulnerable children, monocyte to lymphocyte ratio, CD4, log 10 HIV RNA, and malaria. But we only had 4 that we took into the multivariate regression. And out of that, we only had age and monocyte to lymphocyte ratio that came out important predictors of TB mortality. So to give just a little bit of implication of our results, we actually observed a high TB related mortality among the hospitalized antiretroviral naive children living with HIV. And we also noted that children under the age of 5 were at a higher risk of death. And the high mortality, we hypothesized that this age group may have been due to the immature immune responses to contain the TB disease. Regarding the elevated monocyte lymphocyte ratio, which was above 0.378, we hypothesized that this may have been a reflection of an increased bacteriological burden. And so one of the variables that we were exploring was the monocyte to lymphocyte ratio. And therefore, previously it has not been evaluated as a prognostic biomarker for TB outcomes. And therefore, one of the recommendations we came up with was future studies are needed to validate its clinical use. And also we recommend that future interventions to improve earlier HIV diagnosis and antiretroviral treatment should be considered, and this may improve the TB survival. So one of the limitations that we found in our study is that we had a smaller proportion of patients in this cohort with confirmed TB, and therefore this limited our ability and power to perform extensive stratified analysis. Just to wind up is to first take this opportunity to appreciate a team that we worked together with, starting with my immediate mentor, that is Dr. Lisa Cranmer and Dr. Richard Rothenberg, followed by also the funders to this program. And also I would like to appreciate the EIA research group here at UGA that were really instrumental in terms of inputs and contributions to make this a success. And also to appreciate all of you for listening to me. And I open room for questions, comments, or clarifications.
Okay, thank you for the presentation, Henry, and for joining us today. We do have one question in the chat. Devin asked, how did you measure MLR in individuals? How invasive is the protocol?
Well, I don't have like a direct answer on how the MLR was measured, but maybe just to clear the air on why we chose the value of 0.378, a study was done before and it showed that children who had a 0.378 value of the monocyte lymphocyte ratio were likely to be diagnosed with active TB. Yeah, but the nitty-gritties on how it was measured, I may not be in a position to respond to that as of now.
Yeah, Henry, this is Dr. Whalen, and Devin, I can answer that. It's done from a simple blood smear where you count the number of lymphocytes and the monocytes and then take a ratio of that. I assume it's a proxy for the CD4 T cell count in children. So Henry, question, only 13 of the 181 participants had confirmed TB. Do you know how the TB was confirmed in them?
Yeah, actually, all the children who all the children in this study underwent intensified TB case finding at enrollment, and they were evaluated for TB with symptoms screening, physical exam, and microbiologic evaluation. And when they were taking like the 2 sputum or gastric aspirate samples from the acid fast bacillus, as well as the expert and culture and 1 stool expert. And children who were suspected to have TB were treated based on the Ministry of Health of Kenya guidelines.
Okay. So only 13 of the 181 had confirmed TB. My next question is, did any of them have TB meningitis?
Thank you for asking that. That was part of the inclusion and exclusion criteria. So we excluded all children who had TB meningitis in this study.
Okay. And last question is, did you do a Kaplan-Meier curve comparing the survival of the 13 where you have confirmed versus the survival curve of the 100 and whatever that would be, 68?
We haven't done that, but it's in the pipeline. And as I mentioned, that this is just the preliminary results. So we are still trying to look at the best way to analyze that. And that was part of the plan to do maybe as our next steps.
Yeah, because it's likely that of those 168 or so that were not confirmed, some of them have TB and some of them don't. And it would be interesting to compare the survival curve between those 2 groups.
Yeah, sure. The only survival analysis that we have done as at now is where we are looking at the combined confirmed and unconfirmed versus unlikely TB. Yeah. But I think it is interesting also to look at the one you have just proposed, where we look at the confirmed TB against the other group.
Yeah. I could ask lots of more questions, but I know time is of the essence.
All right, thank you, Henry. I think Kenya is next.
I will be the next person. Dr. Davis, you muted.
Yes, I'm saying, Trong, if you're ready, you ought to be able to share your screen. If
okay,
I think that setting is set.
Okay.
Perfect. Perfect. We're glad that that worked. I know that the connection was posing some problems.
Yeah, so do you see my screen now?
Yes, it looks great.
Okay, so I'm Chang and I'm a PhD, third year PhD student in epidemiology. Today I will talk about the drivers of ongoing tuberculosis transmission in African city, insight into the environment. So TB is one of the top 10 causes of death worldwide. 1/4 of the world's population has latent tuberculosis infection. Around 20% of the transmission occur in the household in high burden countries such as South Africa. Therefore, presumably, the majority of the transmission occur in the community-based setting. However, today, there have been no study designed to confirm the presence of community transmission. Rather, the evidence for the community-based transmission is garnered primarily from a lack of evidence for the transmission in home and hospitals. So we conducted a cohort study of individuals without evidence of latent tuberculosis infection, indicating by tuberculin skin test less than 5 millimeters. At the end of the study, we retested participants with tuberculin skin test to evaluate their TB infection status. As baseline and every treatment visits, we ask participants how they spend their typical day, how they spend their time over the weekend. Initially, we planned to enroll 2,000 participants. However, we could enroll more than 1,600 only. Therefore, the participants who were negative at 12 months with tuberculosis skin test, we asked them to remain in the study and extended the follow-up time. So you can see that we screening more than 8,000 participants to able to enroll 681 participants, and finally we have 1,275 people with the follow-up TST result. So the study had 24% loss of follow-up, or participants refused the tuberculosis skin test. Let me talk about the result of this study. Firstly, the incidence of latent tuberculosis. Over the study period, we detected 194 participants acquiring latent tuberculosis infection, suggesting a cumulative incidence of 15.2%. When we restricting to the 12-month period, the annual risk of infection were 11.8%. In terms of the duration of time spent in a different setting, we asked them, we listed 12 settings, and here you can see that in each panel, you can see the name of the setting, typical day or weekend day. We have three numbers here. The first number is number of the visit. The second is the number of participants attended in a setting. And the third number is the mean duration of time spent. We observed that there are more visits, more participants attended, and longer duration of time spent in old home, other home, worship center, social gathering, bar, hair salon, gym, graduation, and hospital clinic. Over the weekend than the typical day. So in reverse, there are less visits, less participants attended, shorter duration of time spent in workplace, school, shopping site, and public transport over the weekend than typical day. Next, the model to identify the high-risk setting, because we measure the duration of time spent as baseline and every 3-month visits. So when fitting into the model, we use the mean or the max of duration of time spent across the visits at the summary. For the duration of time spent in a typical day, you can see that for both model, mean and the max model, worship center appear place that TB transmission occur. Also, school also spending time at school also increasing the risk of acquiring latent tuberculosis infection. This model is for the duration of time spent during the weekend, and you can see that spending time at school also increasing the risk. For the max model, spending time at home over the weekend could reduce the risk of getting latent tuberculosis infection. So the conclusion is any risk of acquiring latent tuberculosis infection in Africa was high at around 12%. General population spend their time during the weekend was different from their typical day. Worship center and school and community-based testing associated with TB transmission. Staying at home can reduce the risk of acquiring latent tuberculosis. So this study can guide the targeted infection control intervention for National TB Control Program. It's laid out the foundation for the next TB transmission study, employing the molecular epidemiology techniques to identify risk area or target for the point of care diagnosis using the new molecular method. Yeah. I'm done.
Okay, thank you, Trung. Any questions? I don't see anything in the chat, but if you have a question, you can just unmute yourself or use the hand raise. Any questions?
Hi, this is John. Ask a
Yeah.
question. Yeah, hi, Trang. In your table with your regression model results, the title says that they're associated with TB transmission during a typical day. I was trying to understand that. Is the transmission necessarily happening on a typical day, or
Yeah, it's not. Yeah, I think I just want to, just mean that this model, I use the data, measure the duration of time spent during the typical day. It doesn't mean occurring during the,
okay, so the exposure, the time in those microenvironments is the exposure happens during a typical day, maybe.
Yeah.
All right. Okay. Just wanted to make sure I understood that. And could you describe why you were adjusting for some of the variables, the contact with a TB patient, attending drugstores?
Yeah. All the things seem reasonable. Only attending the drugstore, because in my analysis, attending drugstore saw that it reduced the risk of acquiring latent tuberculosis infection, and I. There may be something behind that, but it's hard to explain.
Okay, I guess I was wondering a little bit about the adjustment for having contact with a TB patient. I'm not sure if going to certain places, is that what puts you into contact with a TB patient? And so is that part of the effect of going to those places?
In our study, we see that 19% of the population has exposure to the TB patient, and definitely exposure to the TB patient will increasing the risk of acquiring the TB infection. That's why it's in the model.
Okay. Oh, wow. So there's a very high prevalence of having some exposure. Maybe it would, I guess we can talk offline. It'd be interesting to know the intensity of that exposure, since most people have some. Really interesting. Thank you.
Yeah, thank you, Dr. John.
If I can jump in here, John, you're really hitting on the point. Most TB transmission occurs in settings where the contact does not know that that they're having contact with an infectious case. So by having contact with the TB patient, that would be known contact. So we're really measuring unknown exposure to undetected cases. Yeah.
Thank you, everyone. I believe our time is up for this presenter, and we just have a few more minutes for Kenya, if you're ready. Is that okay?
Okay, I'll share my screen. Can everyone hear me? Okay, excellent. So good afternoon. My name is Kenya Murray. I am a first-year doctoral student within the Department of Epidemiology and Biostatistics. And today I'll be presenting on bioethical issues in the use of mobile phone data and mHealth technologies in the East African region. And this is a scoping review that we did in collaboration with colleagues at Makerere University in Kampala, Uganda. And so as the number of mobile phone subscribers exceed the world's population, the amount of personal information generated through mobile devices is growing exponentially. So mHealth, or mobile health, is defined as medical and public health practice supported by mobile devices. And this includes mobile phones, patient monitoring devices, wearables, tablets, apps, and other functionalities such as voice and short messaging services. And so although mobile phone data is typically used by communication companies for billing purposes and services delivery, public health scientists have recently developed collaborations with this business sector to use mobile phone data for public health research. So what actually does mHealth in research look like? So current evidence has demonstrated the utility of mHealth in solving shortages in healthcare workers, particularly in low and middle income countries, monitoring medication adherence specifically for HIV-infected patients, and also improving quality of care for those who live in remote regions. And also aggregate analysis using these anonymized call detail records. And I'd like to define that. So these call detail records are the metadata that includes specific information about the duration of your call, the number that you called, and the time of your call, just to name a few. So public health and population health scientists have utilized these call detail records to complete innovative analyses that have enriched our understanding of the spatial temporal transmission of various pathogens, including rubella, malaria, dengue, and Ebola, to name a few. However, the use and acquisition of these call detail records is often limited due to privacy and confidentiality concerns. Specifically within the field of mHealth, there's a lack of a standard ethical and regulatory framework to guide the use of these data in health research, particularly within the East African region. So to illustrate the potential ethical breaches that could happen, I want to describe the flow of personal information from a person's mobile phone. And so you have a mobile phone user. And so as their mobile phone connects to a mobile phone network via them making a phone call or using a text, they're generating various pieces of personal information about themselves, including the phone number that they're calling, the actual location of their movement, the cell tower that they're connected to, the day and time of the phone call. And all of these data are potentially or specifically anonymized and then added to a database for public health research. And all of these data points also represent potential threats to privacy if these data points are shared without specific ethical frameworks in place to protect them. And so the objective of our study was to synthesize the evidence on ethical, privacy, and data security concerns related to mHealth technology and mobile phone data use in public health research within an East African context. And so this scoping review was motivated by an NIH funded study actually being guided by Dr. Whalen, the MAT study, mapping out tuberculosis transmission. And so this study particularly takes a novel approach in that it's utilizing individual mobile phone data and combining that with epidemiologic data and also molecular data to map out TB transmission hotspots. And so during the implementation of that study, several of the Ugandan stakeholders just kind of brought up that there were some concerns around ethics and privacy, and there were some gaps in literature for how to address those. So that's the motivation for this study. So we conducted a systematic search of the literature utilizing PubMed database, using specific terms related to mobile phone, health, ethics, and East Africa. And so in terms of East Africa, we included countries of Kenya, Burundi, Rwanda, Uganda, and Tanzania. And so the inclusion criteria for our scoping review was we included studies that were related to mobile technology and health, studies that were published in English from 2000 to 2019, studies that were available in full text, and studies that were conducted specifically within the East African region. And so scoping reviews are a newer form of methodology. So you typically hear about systematic reviews, but we decided to go with the scoping review. And there's a framework that's proposed by Arksey and O'Malley that includes the following activities: identifying the research question, identifying relevant studies, selecting those studies, charting the data, which essentially means abstracting the data, and summarizing and reporting the results. So here I present a flow chart of our results. And so we identified 94 articles from the PubMed database. 5 of them were excluded during stage 1 of our screening process, and 56 were excluded during stage 2. In total, we included 33 articles for additional review within our scoping review. So those 33 studies, the majority of them were observational in study design, and also over half of them utilized SMS text messaging as their mHealth intervention. In terms of countries, 14 were from Uganda, 13 were from Kenya, 5 were from Tanzania, and one study mentioned that participants were from Tanzania and Uganda. I'd also like to note that we did not find any studies from Burundi or Tanzania for our study period. So 5 thematic areas of concern came up or emerged as we analyzed our 33 studies, and they included privacy and confidentiality concerns, regulatory and legal concerns, sociocultural concerns, adequate consent concerns, and data protection and security concerns. So here I present the positive and negative perceptions of participants that were included within our study. So there were both positive and negative perceptions regarding using mHealth and mobile phone data for public health research. On the positive sides, participants felt that they had more privacy utilizing SMS versus face-to-face interactions with providers. They also felt that mobile phones were more private versus collecting data on paper forms. In terms of negative perception, participants were concerned about phone theft if they utilized mHealth technology or their mobile phone data was used for health research. There were pregnancy-related witchcraft concerns, specifically among maternal populations who felt as though if their pregnancy-related information was released from a cell phone or a mobile phone, that witchcraft would be performed on them or their fetus and result in a negative health outcome. And so HIV status disclosure, spousal conflict, and personal linkage of phone data were also negative perceptions of using mHealth technology and mobile phone data. And so the use of mHealth technologies to capture health data may have both positive and negative impacts on perceptions of personal privacy and confidentiality. And the findings of our scoping review suggest that there's a heterogeneity in patient-centered areas of concerns, and they should be considered when implementing or prior to implementing mHealth interventions. Also, our scoping review kind of implores that a comprehensive framework that accounts for the major areas of concern is needed to guide the safe use of these data. And lastly, further research is needed to understand the country-specific concerns regarding privacy and confidentiality. And I'd like to acknowledge our colleagues at the University of Georgia and also our Ugandan colleagues at Makerere University. Thank you. Any questions?
There's one remark in the chat. Consider adding searches of Embase and Cochrane Central Clinical Trials Registry.
Yeah, that's an excellent idea. I was raising this with Dr. Sikandi maybe a couple days ago, in that in searching other databases, I did find some studies from Burundi and Rwanda. So expanding the databases in which we conduct our searches, we may be able to kind of unearth some more, data concerns.
Yeah, I think given that they're Francophone countries, and the search was done for English, that we systematically excluded those countries in East Africa. So, and there may be different cultural concerns in the Francophone countries.
Any other questions for Kenya? Questions or comments?
Yeah, Kenya, I wonder if you can just comment briefly about the different use, how we in our study are using the cell phone data, say, different than most of the published studies.
So in terms of the mobile phone data analysis, I think you're referring to the CDR use. And so the majority of studies that we've come across are using CDRs at an aggregate level. They're not really looking at the individual level. And within the math study, Dr. Whalen, like I mentioned during the presentation, is taking a different approach in that he's using these individual level data to actually map out where people are going throughout the day to figure out where these hotspots for TB transmission are.
Yeah, and by aggregated data, they are anonymized.
Mm-hmm.
So whereas with our data, we know every person in it and their movement and so on. So it raises it, heightens sort of the privacy confidentiality concerns.
This is just a follow-up comment or question to Dr. Ebel. You did mention that there might be some international journals that are not PubMed indexed. What would be some of your thoughts in trying to get those as part of our search? Is Dr. Ebel still there? Probably left. Okay. Looks like he left. I don't see him on the list. Yeah, that's an interesting comment.
Okay, well then we're coming to an end. So I'd like to thank all our presenters today once again, and also everyone who did make submissions to the symposium, even if you weren't presenting today. I put a link in the chat that goes to the website where we've uploaded all the posters and also people's video presentations that they've uploaded on YouTube if you all want to check that out. And then I can leave the floor to Dr. Davis-Olwell or any faculty that wants to make any closing remarks.
Yeah, I would like to just point out at this time, so Global Health Union is a club that started at UGA in 2018. And as I believe Emma said at the beginning, one of their purposes is to link different units across the university that are interested in global health. And up to now, I think the club has included undergraduate students. So all of our organizers today are undergraduate students, but a lot of the activities involve graduate students as well, as you can see today. And if any of you had participated in our case competition. And so I just want to point out that I believe graduate students can also join as members and serve on the different committees within that organization. And I would like to encourage you to think about being part of this club. Every year there's this research symposium and also the Global Health Case Competition. And in addition, the organization has done movies on campus that are global health interest. And they also hold events co-hosted with other student organizations, which I think has been a great way of letting people know more about what's happening at UGA in the area of global health. So I see, yes, there's a plug in the chat if you want to make contact in that way. And I also wanted to thank the judges. We said that initially, but Dr. Whalen, Dr. McCracken, and Dr. Sikandi devoted time to review all of the submissions, and we discussed them Tuesday and made our selection of the finalists. We also noted a group of semifinalists, other presentations that we thought did a great job in meeting those scientific criteria, but also pointing to the relevance to global health. And we just want to thank everyone who submitted, and we hope we'll hear from some of y'all next year.
Yeah, Paul, thank you, Paul. I just want to say to the students, thanks very much. As the director of the Global Health Institute, this is just a wonderful example of what you do with yourselves and with your mentors. I can tell you, I don't know the date, but the last Thursday of April 2022, we will do this again. So I hope that you can plan your schedule around submitting something, and we really look for high quality research to continue among students, and this is a perfect forum for practicing or giving the talk again if you've given it at another meeting. And we really appreciate your submissions and your attendance today. And if we have more interest, we will obviously have to make it more than an hour long.
And we're hoping that it might be in person next year.
Indeed.
All right. Thanks, everyone.
Thanks all.
For coming out.